Okay, we'll begin with the session now. Dr. Manupriya, she'll be speaking on immediate sequential and delayed sequential bilateral cataract surgery, a real world study.
Good morning, everyone. The topic for my paper is immediate sequential. Hello. Good morning, everyone. The topic for my paper is immediate sequential and delayed sequential bilateral cataract surgery in a real world study. So, cataract surgery is the most common surgical procedure performed worldwide, and there is an increasing need for cataract surgery. ISBCS is a procedure where both the eyes are operated in the same sitting. The first documented ISBCS was done in 1952. DSBCS is when the cataracts are operated sequentially, the days, weeks, or even months apart. Now, recent advances in cataract surgery, such as phaco, clear corneal cell sealing incisions, sophisticated biometry methods, have led to accelerated visual recovery and decreased complications. Hence, cataract surgeries have generally become safer. Now, the emergence of COVID-19 pandemic led to the need for decreased number of visits for surgery and follow-up. That led to increased talk about ISBCS. Also, patients with high risk of anesthesia complications, such as children, psychiatric patients, and uncooperative patients, with the risk of morbidity and mortality from anesthesia, are more than the risk for bilateral cataract surgery. However, there are people opposing this with the view that bilateral sight-threatening complications, they outweigh any potential benefits that the procedure may have. The purpose of the study was to assess the safety and efficacy of immediate sequential bilateral cataract surgery and DSBCS in a tertiary care hospital. It was a prospective observational study. Study period was 3 years. Participants of all age groups with bilateral cataracts were operated in the same sitting or within 6 weeks of each other were included in the study. Exclusion criteria were associated glaucoma, ocular extraocular infections, prior history of end-off or ocular injury, high myopia, patients lost to follow-up. So 190 patients were included with 18 patients in group A with ISBCS and 172 patients in group B with DSBCS. Detailed pre-op assessment was done, including visual acuity, tonometry, slit lamp, and fundus examination. All the surgeries were performed by a single experienced surgeon. Strict asepsis was maintained. In ISBCS, each eye was treated as a separate procedure. The eye with advanced cataract was operated first. Standard phaco was done using a 2.8 mm incision. Before operating the second eye, both the surgeon and the assistant changed their gowns and gloves in ISBCS, and a new trolley with separate full cycle autoclaved instruments were used. Post-operative, regular medications were given, and in ISBCS, separate post-op kits were given for each eye. Follow-up examinations were done on day 1 week, 4 weeks, and 6 months. Statistical analysis was done using SPSS. In the results, the mean age in group 1 was 23, whereas in group B was 61. And the male and female ratio was comparable, and the pre-op visual acuity ranged from 6/6 to PL present. The most common associated ocular condition was corneal haze in both the groups, and a systemic condition was diabetes and hypertension in both the groups. The intra-op and post-operative complication rates in both the groups were comparable, and they were also very low. Most commonly, they were PCR and vitreous loss, and post-op complications were keratitis and anterior uveitis. Now, the post-operative visual acuity in ISBCS group at 6 months, 50% patients had 6/6 to 6/12 vision, and in group B, 81 patients had 6/6 to 6/12 vision. This difference was statistically significant. Now, the International Society for Bilateral Cataract Surgeons gives a general set of guidelines for selecting patients for ISBCS and also the aseptic precautions that need to be followed while performing an immediate sequential bilateral cataract surgery. And in any case, if there's any complication with the first eye, then the second eye surgery can be delayed. Now, the Helsinki Simultaneous Bilateral Cataract Study Report 1 was a clinical trial done in 520 patients, which found out that the refractive outcomes and rate of complications between both the groups was similar. Now, this is a list of previous publications in immediate sequential bilateral cataract surgery, and as we can see, that the rate of complications is very low and almost zero in the recent studies. Now, most studies randomized the patients to the two groups. However, we selected the patients based on their individual requirements. So, 12 were children, 3 had psychiatric disorders, and 3 were elderly patients with multiple systemic disorders. Now, there was no statistical difference in the intra-op and post-op complications in our group, which is in accordance with other studies. And there is statistically significant difference in the visual acuity in both our groups. That is because in the first group, there was difficulty in evaluating the visual acuity because some were psychiatric patients and some were children below 2 years old. Now, the conclusion is that should be meticulous case selection, proper asepsis protocols should be followed, and proper routine follow-up should be done. And therefore, we can conclude that there is no added complication in ISBCS when compared to DSBCS, and it is a safe and effective procedure. Limitations of the small sample size and the huge number of patients in one group as compared to the other. These are my references. Thank you.
Thank you, Dr. Manupriya. Very nice presentation. I would like to ask this one question. What were the complications faced by you in the immediate sequential bilateral cataract surgery?
No, basically, we only selected patients that really needed immediate, like patients who had psychiatric disorders or who had high risk of anesthesia. We had one patient who had mental disorder and had CKD. With a lot of effort, the nephrologist could control his urea and creatinine. So we need to operate both of his eyes together. Thankfully, in all the 18 cases, none of the patients, the first eye had any complications. So this is a guideline given by ISBCS also, that if the first eye has any major complication like PCR or vitreous loss, or if the surgeon feels, then we should and we can and we should abandon the second eye surgery.
Yes.
So thankfully in these 18 patients, none of the eyes had, the first eye had any complication, so we could proceed with the second eye surgery as well.
Okay, thank you.
Thank you.
So the next speaker is Dr. Arpit Srivastav. He will be speaking on the topic air tamponade versus corneal wound hydration, a multicentric study.
Hello. Good morning, everyone. Today I will be speaking about a multicentric trial which we have conducted to know the post-operative differences of air tamponade versus corneal wound hydration in cataract surgery. So basically what we all know and practice, there are two approaches to seal the clear corneal incision of phacoemulsification surgery. One is in which we hydrate the wound, and the other one is intracameral layer, which presses the wounds internally and cause the sealing of the wound. Basically, we have done a multicentric trial involving 3 surgeons to know the post-operative results of these two, and which can help surgeons to make a better evidence-based decision. Previously also there has been a lot of work which has been done, and in most of these studies what they have emphasized is that corneal wound hydration causes the swelling of the wound and the change in the architecture of the wound. That's why the post-operative astigmatism is more. Our study also aligns with the previous study, with the advantage being it's a multicentric trial, so it has more external validity, and we have focused more on the functional outcomes like vision, so that a clear-cut decision can be taken. We have taken 300 eyes for this study, and 150 was put in the air group and 150 in the hydro group. Each surgeon operated upon 100 eyes. All the surgical parameters, including the phacoemulsification machine, the site and size of incision, the type of surgery, the consumables used in the surgery, all were kept same for all 3 surgeons. The inclusion criteria for all the patients where that the cornea should be clear before the eye, the pre-operative astigmatism and anterior chamber depth, all the other parameters which can affect the corneal clarity was kept within a strict defined range. Any eye in which intraoperative complication happened, or any eye which has a visible corneal edema on the postoperative day 1 was excluded from the study. Patients were followed up on day 1, 7 and 28, and on each visit visual acuity was calculated in logMAR, corneal astigmatism power, intraocular pressure and CCT was calculated. So this was our result on post-operative day 1, in which we can see that in terms of visual acuity, the air group has a slightly better vision as compared to the hydro group, which was statistically significant. Corneal astigmatism power was much high in the hydro group, which was highly significant. Intraocular pressure was slightly higher on the air group. CCT was almost same in both the groups. And if we talk about local DMD, then we had 23 cases in the hydro group as compared to 7 cases in the air group. So the results on post-operative days 7 and 28 were almost the same. There was no difference between these two groups. This is a typical OCT photograph in which we can see the distortion of the architecture in cases of corneal wound hydration, causing more swelling and causing more post-operative astigmatism. These are some more photographs in which we can see that in the hydro group, how the wound architecture is distorted, and in one case we can also see local DMD. So our results were clear. Intracameral air preserves the anatomy of the corneal wounds more. That is why it causes less post-operative astigmatism and a better visual acuity on post-operative day 1. However, after 1 week, the result between these two groups, these two methods are almost the same. So based on what we have conducted, our recommendation is that intracameral air is slightly better as compared to stromal wound hydration if the eye is patched for 24 hours. One has to be careful if immediate visual recovery is needed and eye is not being patched. And other thing is we have to be careful about the overfilling of the anterior chamber, because of the overfilling there can be IOP fluctuation, and in some cases the air bubble can all present in the pupillary area even after 24 hours of patching, in which the vision will be decreased and it will cause apprehension to the patient. So these are my references. Thank you.
Very well spoken. Thank you.
Okay, thank you.
Our next speaker is Dr. Yash. He'll be speaking on the topic comparing the visual outcomes and satisfaction in monofocal and EDOF IOL recipients.
Good morning, respected chairperson and all delegates. Myself, Dr. Yash Hingankar, and today's topic of discussion is to compare visual outcome and satisfaction in monofocal and EDOF IOL. Cataract surgery is the most common ophthalmic procedure worldwide, with intraocular lens implantation being the standard of care. Monofocal IOLs were developed to provide excellent post-operative distance vision, but it had certain limitations as they require glasses for intermediate and near vision. Multifocal IOLs were designed to improve uncorrected near and intermediate vision, but it had some disadvantages such as halos and glare. Therefore, EDOF IOLs were developed to overcome multifocal limitations. Many patients already have a monofocal IOL in one eye but remain unsatisfied with intermediate or near vision. Therefore, implanting a monofocal IOL in other eye could be considered, but it had limited satisfaction due to reduced binocularity. Therefore, implanting a multifocal IOL in the fellow eye had many quality issues such as glares and halos. EDOF IOL in the fellow eye would be the ideal balance, as they had been extending the range of vision, reducing spectacle dependence and maintaining visual quality. The main aim of our study is to evaluate and compare visual outcome and patient satisfaction in monofocal pseudophakic patient who subsequently received an EDOF lens in the other eye. These are the objectives of my studies, that is to assess the visual outcome and patient satisfaction in patients implanted in monofocal IOL in one eye prior to the cataract surgery with EDOF lens, to assess the visual outcome and patient satisfaction in monofocal pseudophakic patient implanted with EDOF IOL in the other eye. Third is to compare the visual outcome and patient satisfaction before and after implantation of EDOF IOL in monofocal pseudophakic patients. My study is a follow-up study design which was done in the Department of Ophthalmology at a tertiary care hospital for a period of 1 year, and sample size was 60. The inclusion criteria consisted of monofocal pseudophakic patients with senile cataract in other eye, and the exclusion criteria were as follows. Ethics approval and confidential ethical clearance was obtained from the institutional committee. A pre-designed proforma was used to record the following patient details. Detailed ocular examination consisted of uncorrected visual acuity, best corrected visual acuity, intermediate vision assessment, near vision assessment, anterior segment examination was done using slit lamp, and cataract grading was done using the LOCS grade 3 system. Cataract surgery was done using phacoemulsification technique. At each visit, monocular uncorrected visual acuity was done at each visit on day 1, day 7, and day 21. The following parameters were evaluated, and the response was categorized according to the following details. This is the graph showing age-wise distribution of patients, where we can see that most number of patients were from the age group of 60 to 65 years. This table shows the preoperative visual acuity among monofocal versus cataract eye, where we can see that most number of patients had a good distant vision of 6/9. This table shows the preoperative intermediate versus near vision among monofocal and the cataract eye, where we can see that most number of patients had an intermediate vision of N18, whereas the near vision was also of N18. The table shows patient satisfaction with monofocal lens in one eye and cataract in the other eye. As we can see that most number of patients were happy with their distant vision, but when it comes to their intermediate and near vision, they categorize their vision from fair to poor. The table shows post-operative distant vision for EDOF lens, where we can see that most number of patients had a good distant vision of 6/9 after post-op day 21. This is the pre and post-operative comparison of visual outcome in monofocal and EDOF IOL. We can see that most number of patients had a good near intermediate vision of N6, whereas most number of patients had a good near vision of N10 in the EDOF IOL group. The table shows pre and post-operative patient satisfaction in the monofocal and the EDOF group, where we can see for distant vision, both the patients were happy with their distant vision, but for the intermediate and near vision, the EDOF group were comparatively happy than the monofocal group. The EDOF group demonstrated significantly better uncorrected intermediate and near visual acuity compared to the monofocal group, while distance vision remained comparable. Patient-reported outcomes showed higher satisfaction and reduced dependence on spectacles in the EDOF group. It may reduce the need for glasses for some tasks, particularly at intermediate distance, but may still require glasses for near vision. This is our study, which was compared to the 3 other studies. To conclude, implantation of EDOF IOL in monofocal pseudophakic patient enhances intermediate and near visual acuity while maintaining distance vision, leading to improved overall patient satisfaction and quality of life. These are my references. Thank you.
Thank you, doctor. Very nice presentation. Next, I would like to call upon Dr. Lekhna. She'll be presenting on soothing sounds in sight, the role of music in reducing anxiety during cataract surgery.
Good morning. Today's topic is on effect of music on preoperative, intraoperative and postoperative anxiety in patients who are undergoing manual small incision cataract surgery. So coming to anxiety, almost 32% of the people report anxiety when they undergo cataract surgery under local anesthesia, which may be due to various factors like being aware and awake during the procedure, hearing surgical sounds, seeing unusual lights or vague movements, worrying about the involuntary eye movements or blinking, and experiencing claustrophobia from surgical drapes which is covering the face. So modes of decreasing anxiety, there can be pharmacological sedation, which includes use of midazolam, alprazolam and fentanyl. Multimodal approach, which combines preoperative counseling, mild sedation, music therapy, which gives the best anxiety control during cataract surgery under local anesthesia, and music therapy. So the purpose of the study, we use this to compare preoperative and postoperative anxiety score between the patients with and without music therapy prior to the surgery. So to determine the proportion of anxiety-related hypertension in patients undergoing small incision cataract surgery, which is performed under local anesthesia, and to compare the proportion of intraoperative complications between the cases and controls. So we have taken a sample size of 154 from the CAM patients who undergo their first cataract surgery. So the inclusion criteria is that, and the exclusion criteria, which excludes severe hearing loss, speech impairment, uncontrolled hypertension and psychiatric disorder. Informed consent was taken. And cases were 77 and controls were 77. In cases, prior music therapy was played for 20 minutes pre-operatively, which was selected by an expert musician, and in controls, no prior music therapy. So the parameters measured were pulse rate, SpO2, blood pressure, and Hamilton anxiety score pre-operatively, intraoperatively, and post-operatively. So the results, when we compare the control and mean, there were significant decrease in the anxiety and in the parameters of blood pressure, pulse rate, and Hamilton anxiety score. So here we can see the results, which is less than 0.01 with the test of asymptomatic significance. So conclusion, music therapy is safe, it is simple, cost-effective therapy which can adjunct to routine care, and it reduces the need for pharmacological sedation. And it significantly reduces anxiety in the preoperative, intraoperative, and the postoperative period. Better cooperation and lesser interruptions during the surgeries in the patients who undergo manual small incision cataract surgery. So the Hamilton anxiety score that we have used here, we scale it from 0 to 4, where 0 is not present and 4 is very severe. So a total score of 0 to 56 is given, where less than 17 is mild, 18 to 24 is moderate, 25 to 30 is severe, and more than 30 is very severe. So most of the patients in the cases where the music therapy was played fell under 0 or very mild, that is less than 17 score. Thank you.
Thank you, doctor. It's a very nice and novel study. And what were your experience? What was your experience? Feedback of the patients?
The feedback was very nice. A few limitations where the patient's preference of the music was not there, because we selected classical instrumental Indian music, so that preference was not there. But the feedback from the patients were very nice. They were very
Most of the
relaxed.
patients were satisfied.
Yeah, post-operatively their feedback was better in the cases than the controls.
Okay, thank you.
Thank you.
So our next speaker is Dr. Parima Mittal. She'll be speaking on the topic of prospective evaluation of visual outcomes and complications in cataract surgery of diabetic patients.
Good morning, everyone. The topic of my paper is a prospective study to evaluate complications and visual outcome in cataract surgery of diabetic patients. Introduction: diabetes causes many ocular complications such as cataracts and diabetic retinopathy, which are the main causes of decreased vision in diabetic patients. Cataract occur more frequently and earlier in diabetic patients than in non-diabetic patients. Microangiopathy, altered wound healing mechanisms, and the potential for increased inflammation in diabetic eyes poses challenges on surgeons which are seeking optimal surgical outcomes. Moreover, the presence of diabetic retinopathy further complicates the intraoperative and postoperative assessment. Aims and objectives includes to evaluate intraoperative and postoperative complications in cataract surgery of diabetic patients, to assess visual acuity in cataract surgery of diabetic patients, and to study the effect of cataract surgery in diabetic retinopathy. Inclusion criteria includes the patients above age of 18 years that are having diabetes and undergoing cataract surgeries, and eye cataract patients having diabetes. Exclusion criteria: any ocular or systemic conditions that can cause macular edema other than diabetes, patients with history of ocular trauma, vitreoretinal surgery or glaucoma surgery, patients with any ocular or systemic comorbidity which will hinder fundus examination and OCT, and patients with proliferative diabetic retinopathy. The type of the study is prospective study in upgraded Department of Ophthalmology, NSCB Jabalpur, and the study duration is of 1 year with a sample size of 100. These are the pre-operative assessment that are done, and observation and results includes there are more patients which lie in the age of 61 to 70 years, followed by 51 to 60 years. 57% were females and 43% were males. The most common diabetic cataract was cortical cataract, followed by nuclear and posterior subcapsular cataract. More patients are suffering from diabetes since more than 10 years. Most common intraoperative complication is intraoperative miosis, followed by excessive pigment release, PCR, zonal dialysis, vitreous release. Most common early post-operative complication is corneal edema, followed by post-operative inflammation, iritis, retained cortical matter, raised IOP, iris prolapse, and hyphema. Most common late post-operative complication is diabetic retinopathy progression, followed by cystoid macular edema, PCO, and recurrent uveitis. There is improvement in the visual acuity both on post-operative day 1 and 21. There are 60% patients which are affected with diabetic retinopathy, while 40% are patients with diabetes but without retinopathy. There are, out of this 60% patients, mild NPDR patients are 28%, moderate to severe NPDR at 8%. And this is the graph which represents the progression of diabetic retinopathy in diabetic patients after cataract surgery. This shows the assessment of, this line diagram represents that there is an increase in the macular thickness from pre-operative to post-op day after 1 month of the cataract surgery, while there will be a decline in the macular thickness post-operatively after 3 months. This is the OCT image which shows that there is an increase in the macular thickness. From pre-operatively it is 390 and post-operatively it is 411 micron. Conclusion, visual acuity will improve significantly. The most common long-term complication after cataract surgery in our study is diabetic retinopathy progression. Pupil dilatation is also a problem for these patients. It has been concluded that the presence of diabetic retinopathy will definitely affect the prognosis in terms of prolongation of cystoid macular edema. Take-home message, preoperative counseling is crucial for diabetic patients. Before surgery, patients should have good glycemic control. Visual acuity improves significantly in diabetic patients after cataract surgery, but progression of retinopathy after cataract surgery is another problem in diabetic patients. Hence, it is important to reduce the time and complexity of the surgery. Diabetic population is still at the risk of vision-threatening complications, and the preoperative, intraoperative, and post-operative factors are important in management of such complications. These are my references. Thank you.
Thank you, doctor. I would like to ask that was the diabetes grading done prior to the cataract surgery?
Ma'am,
Grading of diabetic retinopathy in the patients in whom cataract surgery was
yes, ma'am,
carried
it was
out?
done. Ma'am, it was segregated on the basis of mild, moderate, and severe NPDR, and PDR patients were excluded from my study.
Okay.
Thank you, ma'am.
So our next speaker, Dr. Hiteshi, not present. I am the next speaker, Dr. Aradhna. Good morning all. First of all, I would like to thank AIOCMTC for providing me the opportunity to share my case. Let's begin with the case. My patient is a male teenager born out of non-consanguineous marriage, and he presented to us with diminution of vision in both the eyes, right eye more than the left eye, for a period of 8 years. He also complained of shortness of breath and palpitations, for which he was referred to the medicine department, and there was no such family history. On ocular examination, in both the eye, there was lens subluxation seen superonasally, and fundus was myopic. It was highly tessellated with this normal and peripapillary atrophy, and the peripheral retina was normal. On visual examination of the right eye, uncorrected visual acuity was 2/60, improving to 6/24, and in the left eye, it was 6/60 and improving to 6/18. On systemic evaluation, the patient was of tall and thin stature, and his arm span was more than the height. There were few more systemic findings: tall and thin fingers, arachnodactyly, high arched palate, thumb sign and wrist sign was positive, and pectus excavatum. On investigating the patient, we saw dextroscoliosis of the thoracic vertebrae, and on the echocardiography revealed the aortic root dilatation. Biometric evaluation revealed myopia, axial myopia in both the eye, and keratometric readings were also raised. So we diagnosed the patient of bilateral ectopia lentis secondary to the Marfan syndrome. And there was, according to the modified Gens criteria, the systemic features and ocular signs as seen in my patients were as follows. So the patient underwent right lens aspiration with anterior vitrectomy, and it was followed by SF IOL implantation, secondary IOL implantation, which was done after 1 month, and currently his visual acuity is 6/12 in the right eye. He is on regular follow-up with medicine and orthopedics department because of the presence of the other findings of aortic root dilatation and dextroscoliosis. Therefore, Marfan syndrome is an autosomal dominant connective tissue disorder caused by the FBN1 gene mutation. The auricular involvement is 60% and ectopia lentis is the hallmark with superotemporal displacement. The uniqueness of my case is the bilateral superonasal subluxation, and this is the atypical direction which is rarely documented. Management involves the ophthalmic care along with the cardiology monitoring and genetic counseling. Therefore, to conclude, bilateral ectopia lentis is not just an ocular finding, it is a window to the systemic disease. Therefore, a comprehensive care involves the multidisciplinary approach. Managing Marfan syndrome is about saving both the sight and life of the patient. Ophthalmic manifestations can significantly impact the vision and quality of life, which requires a regular follow-up. Thank you. Our next speaker is Dr. Harita. Is she there? So I would like to call Dr. Arundhati Devedi. Is she there? Dr. Arundhati. Dr. Anjali. Dr. Anjali will be speaking on the topic specular microscopy evaluation of endothelium in manual ascites in a tertiary healthcare center.
Good morning, everyone. My topic is specular microscopy changes in manual small incision cataract surgery, a prospective observational study. So cornea contributes to 75% of the refractive power of the eye, and this transparency is maintained by the endothelial cell layer via sodium-potassium pump. Specular microscopy is the best method to evaluate the endothelial cells. A minimum density of 400 to 500 cells per mm square is required to maintain the transparency of the cornea. When further cells are lost, cornea imbibes water, corneal decompensation occurs, leading to vision loss. My aim of the study is to study specular microscopy changes before and after manual small incision cataract surgery. My primary objective is to assess the endothelial cell loss, observe changes in central corneal thickness, and my secondary objective is to determine any possible association between post-operative visual acuity and endothelial cell loss. It's a prospective observational study conducted over a period of 9 months at ISPA General Hospital, Rourkela. My study population was cases undergoing SICS at the hospital, and study size was calculated using Cochrane's formula and came to 100 cases. Patient diagnosed with cataract undergoing SICS underwent routine preoperative evaluation along with specular microscopy. We used TOMI EM 4000 to assess the endothelial cell density, coefficient of variation, hexagonality, and central corneal thickness. All the operations were conducted by a single surgeon. We followed up the patient on day 1, 7, and 1 month. All cases of uncomplicated cataracts which were observed above the age of 40 years were included in this study, and this is my exclusion criteria. These are the preoperative evaluation. On surgical techniques, I would like to highlight that we use local peribulbar anesthesia, and the incision type was 6 mm Frown superior scleral incision. Continuous curvilinear capsular rhexis was used in majority of the cases, and the nuclear prolapse was by Werter sandwich method in majority of the cases, and we use 6 mm optic polymethyl methacrylate IOL. Coming to results, in my study population, the majority of the population were males, 58% males, and majority of the population were within 60 to 69 years of age group. Preoperative endothelial count, majority were within the range of 2,500 to 3,000. Majority are presented with nuclear sclerosis grade 3 followed by dense cataract NS4 plus 22 and NS2 16. Then we graded the average preoperative endothelial cell density was coming to 2,610. We calculate endothelial cell density at 1 week, and cell loss at 1 week, endothelial cell density at 1 month, and cell loss at 1 month, which came that endothelial cell loss at 1 week was 6.17% and cell loss at 1 month was 12.564%. And this difference was 6.94%, so most cell loss occurred between 1 week and 1 month, especially in higher grade of cataracts. The mean central corneal thickness increased by 8.5% at 1 week, which resolved by 1 month, with residual thickness still which was increased by 1.8%. There was mean increase in coefficient of variation by 6.97%, suggesting polymegathism, and hexagonality decrease suggesting pleomorphism. Mean decrease was by 10.2%. We also assessed visual acuity post-operatively at 1 week and 1 month, and we observed there was excellent recovery in lower grades of cataract, and there was significantly delay or slower recovery in dense cataracts. IO operated within 10 minutes of time showed minimum cell loss and with good visual recovery at 1 week. In contrast, more than 20 minutes had higher cell loss and greater corneal edema and significant delayed visual recovery. This study evaluated the changes of endothelial cell density, CCT, coefficient of variation, hexagonality. The results reflects both structural and functional corneal changes post-operatively, consistent with existing literature. So endothelial cell loss in my case was 12.546%. Higher nuclear grades NS3 to 4 was associated with greater and absolute percentage cell loss. Central corneal thickness was increased by which was resolved by 1 month, showing temporal stromal hydration due to endothelial dysfunction post-operatively. Morphological changes, CV increase and hexagonality decrease, suggesting this changes follows a pattern of initial insult and partial recovery, mirroring endothelial functional reserve. Duration of operations strongly correlated with the endothelial cell loss and visual recovery. This suggested that endothelial trauma due to extended manipulation, AC instability, and mechanical stress, highlighting the need for skills, techniques, optimized nuclear delivery, and endothelial protection to improve postoperative outcomes. My visual recovery is inversely related to the percentage cell loss, especially at 1 week. These are the correlation with the other studies. And to conclude, SICS remains affordable and machine-independent technique suitable for resource-limited settings, which gives good results. This study highlights the importance of thorough assessment of patient and surgical efficiency to enhance surgical outcomes. Thank you.
Thank you, doctor, for the talk. Dr. Meenakshi, Dr. Sheetal, Dr. Vandana. She'll be speaking on assessment of choroidal thickness with varying degree of myopia using enhanced imaging SDOCT.
A very good morning to respected chairperson, judges and my colleagues. I have done my study on the assessment of choroidal thickness with varying degree of myopia using enhanced depth imaging STOCT. As we all know, myopia is a leading cause of visual impairment worldwide. Progressive myopia is associated with structural changes in the posterior segment of the eye, particularly to the choroid layer. The recent research has indicated that the choroidal thickness is essential in myopia development, as the function of photoreceptor cells and the visions are significantly impacted by the variation in the choroidal thickness. Understanding these three factors, the choroidal thickness, degree of myopia, and the best corrected visual acuity, can help in the clinical evaluation and the visual prognosis. My primary objective is to evaluate the association of choroidal thickness with different grades of myopia using STOCT, and the secondary objective is to correlate choroidal thickness with best corrected visual acuity. It is a cross-sectional observational study where I have taken the 60 patients, that is the 120 eyes, which was further divided into three groups, the group A, B, and C, with low, moderate, and the high myopia respectively. I included all the patients with myopia greater than 1 diopter with clear ocular media and excluded patient with dense media opacity, macular disease, amblyopia, glaucoma, strabismus with prior vitreoretinal surgeries, and the concurrent antivascular growth factor therapies. So I have taken the OCT scans at the macular area and measured the CT by drawing a perpendicular line between the outermost part of the hyperreflective line that represents the RP and the hyporeflective line that represents the choroid scleral surface using a caliper at the subfoveal region. These are the OCT scans. You can clearly see the visually difference between the choroidal thickness between the three groups, the low, moderate and the high myopia. I found that the subfoveal choroidal thickness decreased markedly with increasing myopia, that is in the group A 315, 224 with a moderate and 155 with a group C with a significant p-value. Similarly, the best corrected visual acuity deteriorates across the group with significant p-value, and also the subfoveal choroidal thickness shows an inverse correlation with the spherical equivalent. This is a bar chart between the choroidal thickness and the different grades of myopia, which shows the significant negative correlation, and a scatter diagram between the choroidal thickness and the visual acuity, which shows a positive correlation. So I conclude that the choroidal thickness significantly reduces with increasing degree of myopia. The thinner choroid is associated with the poorer best corrected visual acuity, and it can be served as a structural biomarker and offers an anatomically targeted approach for monitoring the progression of myopia and the visual prognosis. Thank you.
Nice talk, doctor. I would like to ask one question related to how can we slow the progression of myopia?
Ma'am, we can monthly or 3 monthly follow the patients. If the visual acuity decreases, we can offer them atropine eye drops for the.
What concentration of atropine is used for such cases?
Ma'am, the low dose atropine eye drops, which is 0.05%, are better tolerated and have a better effect by the ATOM studies which have earlier done.
0.01% is attributed to the low.
0.05.
1%.
1.
And any other study you know regarding the slowing the progression of the myopia?
Sorry, ma'am.
DESC study has been done in students in the COVID times. DESC study. Digital eye strain studies in the kids, which shows that the sun exposure, it slows down the progression of myopia and increases the choroidal thickness. Okay. Thank you. Our next speaker is Dr. Jamie Patel. She'll be speaking on the topic anterior lamellar capsular defect in a child with Down syndrome, a rare presentation.
Good morning everyone. Today I am going to talk about anterior lamellar capsular defect in a child with Down syndrome, a rare presentation. Congenital cataracts are one of the most important and preventable causes of childhood blindness worldwide. They account for nearly 7.4 to 15% of pediatric blindness and demand timely diagnosis and intervention to avoid irreversible amblyopia and poor visual outcomes. Down syndrome is associated with broad spectrum of ocular abnormalities such as strabismus, nystagmus, refractive errors, nasolacrimal duct obstruction, blepharitis, and congenital cataracts. In children with Down syndrome, atypical morphological variants of congenital cataract have been documented. These include anterior capsular plaque, fan-shaped cataract, membranous cataract, and capsular fibrosis. To the best of our knowledge, this is the first documented case of an unilateral anterior lamellar capsular defect in a child with Down syndrome, a rare congenital anomaly that compromises lens integrity, predisposed to early opacification, and complicates capsular axis. Presenting a case of 1-year-old child with a known diagnosis of Down syndrome with whitish opacity in both eyes since birth. Ocular history were not significant except abnormal visual behavior apart from poor fixation and following of object. Systemic history, the child was a known case of Down syndrome associated with delayed developmental milestone. There was no significant family history present. Birth history was normal. In ocular examination, bilateral congenital cataracts were noted. The patient was planned for sequential cataract surgery under general anesthesia. After inducing general anesthesia and maintaining aseptic precautions, a temporal clear corneal tunnel marked with 15 number blade and entry made with dual bevel keratome. Side put entry made with angled MVR braid, injection air dye and visco injected in anterior chamber subsequently, and anterior lamellar capsular defect was noted in left eye, capsular axis performed, gentle hydrodissection done, lens matter aspirated using automated irrigation aspiration, a hydrophobic foldable PCIOL was implanted in the bag, irrigation aspiration done to remove viscosurgical devices, stromal hydration done at incision site, subconjunctival injection given, eye patched at the conclusion of the surgery. In this image, you can see the anterior lamellar capsular defect. For a right eye, similar to left eye, cataract extraction done without any atypical finding after a gap of 7 days. Congenital cataracts are major cause of preventable childhood blindness, especially in children with Down syndrome who are predisposed to various ocular anomalies. Anterior capsular anomaly represent an uncommon and underreported spectrum of developmental defect in these patients. The documentation adds to the limited literature and may provide insights into cell morphology and capsular embryology. The embryological basis may involve defective capsule development and abnormal lens fiber differentiation. This case highlights the importance of detailed intraoperative assessment as rare capsular anomalies may impact surgical planning and IOL placement. This case demonstrates a rare intraoperative finding of an unilateral anterior lamellar capsular defect in a child with bilateral congenital cataracts and Down syndrome. Careful intraoperative evaluation is essential to identify such anomalies and perform safe surgery despite the capsular weakness. Timely cataract extraction with IOL implantation can provide good visual rehabilitation and prevent amblyopia. These are my references. Thank you.
Very nice case. I would like to ask any other findings were present only in this patient or
No,
only
ma'am.
this?
No, ma'am. Only unilaterally we have found anterior lamellar capsular defect. No other
At the time
finding
of surgery.
at the time of surgery. It was an intraoperative finding.
Okay, and what other
We can found. There are many documentation available about anterior lamellar plaques, but no document available regarding lamellar defects.
I'm asking any other ocular findings except this anterior lamellar defects, which you can see in a case of Down syndrome.
Like strabismus, nystagmus, and nasolacrimal duct obstruction can be seen.
Okay, brush wheel spots on the iris are more pathognomic in a patient of Down syndrome. Okay, thank you.
Thank you, ma'am.
So with this, we conclude this session. I'll call upon the speakers for a good photograph if anybody is here. Anyone present?